Good morning, respected teachers. Today I am going to present a topic on observational study on premaxillary setback and repair of bilateral complete cleft lip in a single tertiary care center in Kolkata. Cleft lip and palate are among the most prevalent congenital craniofacial anomalies worldwide, with an estimated incidence of 1 in 700 live births, and in India, the prevalence is approximately 1.4 per 1000 live births. Bilateral cleft lip presents unique surgical challenges due to wide cleft gap and protruding premaxilla. Traditional management involves pre-surgical orthopedics, which reduces premaxillary protrusion and tension prior to definitive lip repair. But because of unavailability of the orthodontics, we address this limitation by single-stage surgical protocols have been explored here. Coming to objectives, to assess the outcome of the single-stage repair of bilateral complete cleft lip along with simultaneous premaxillary setback without any previous dentofacial orthopedics. Coming to the method, it is an observational and prospective study done for last 2 years with a sample size of 25, and the study includes all bilateral complete cleft lip child with age from 6 months to 2 years with premaxillary protrusion greater than or equal to 10 mm who did not undergo any previous dentofacial orthopedic treatment. Coming to surgical steps, first of all, surgical markings. First, the filtral flaps were marked. The length of the filtral flap were equal to the length of the prolabium, and the width of the filtral flap were depends on the age of the child. And the filtral flap were marked concave, and the lateral labial markings were done as shown in the figure. After infiltration of the local anesthesia, after vomerine premaxillary suture was identified, and 5 mm posterior to the VPS suture, we have done the vomerine ostectomy using a 2 mm osteotome after raising the mucoperiosteal flap. And after ostectomy was done, the premaxilla was stabilized with either K-wire or bilateral gingivoperiosteoplasty. K-wire were preferred when the premaxilla was rotating or greater than 14 mm protrusion, and bilateral gingivoperiosteoplasty was preferred when the protrusion was less than 14 mm. After the setback done, then lip dissection was done as per marking, and internal extension of the incision was done over the gingivolabial sulcus. Meticulous dissection of the orbicularis oris done. First of all, nasal floor was sutured and lip sutured in layers. This is a picture showing the final closure. Now coming to results, we had 25 cases, out of which 15 were males and 10 were females, and mean age was found to be 10.4 months. The premaxillary status was in 21 patients they were protruding, and in 4 patients it was rotating type. Mean protrusion was found to be 13 mm, minimum of 10 mm, and maximum was found to be 18 mm. Mean ostectomy done was 5.9 mm, and wedge excision of woman was correlated with premaxillary status protrusion, and p-value was found to be satisfactory. This is the chart showing the correlation between premaxillary protrusion versus ostectomy. Out of 25 patients, 7 had undergone K-wire fixation and rest were undergone gingivoperiosteoplasties. And aesthetic outcome was good with good muscle continuity and symmetry. Coming to complication, there were no major complication. Minor complications such as minimal premaxillary instability and mucosal infection were found. Minimal premaxillary instability was found in patients who had undergone gingivoperiosteoplasty, and mucosal infection were found who had undergone KOR fixation. These are some pre-operative and post-operative photographs. This is a 6-month-old child with premaxillary protrusion of 18 mm who had undergone KOR fixation, and after KOR fixation, this is the photograph and last final closure photo. This is a 11-month-old child with premaxillary protrusion of 14 mm and undergone osteotomy of 6 mm. And fixation was done by bilateral gingivo-periosteoplasty, and the complication was found to be minimal premaxillary instability. This is the third case with a 10-month-old child with 13 mm premaxillary protrusion, undergone osteotomy of 6 mm, and fixation by bilateral gingivo-periosteoplasty. This is a child with 12 mm premaxillary protrusion and undergone osteotomy of 6 mm, and there was no post-op complications. This is a patient who had 17 mm premaxillary protrusion, undergone osteotomy of 9 mm and fixed with KY. Coming to the limitation of the study, though it is a short follow, hence long-term complications such as mid-face retrusion or dental occlusion, we cannot assess that, hence long-term follow-up is needed. In the conclusion, one-stage correction is feasible and safe and effective and is suitable when orthodontics are not available. These are my references. Thank you.